Hey guys, so I did a fistulagram with Dr. Walters, one of my interventional radiologists. So I'm going to go over that today with you guys. So this patient is chronically in the hospital, more just because of what else he has going on with his history. His labs were pretty normal. White count was normal. Red blood cells were a little low. Everything else looked good. His creatinine and bun were a little high, but he is on dialysis. He is a routine dialysis patient, so that was no problem. Going over his allergies, no allergies to iodine or anything that we would use during the procedure. He didn't have any prior imaging for his fistulagram. It was just reduced flow, the thrill of a fistulagram where the vein and the artery tied together wasn't really there. There was like a thumping, not really the true thrill. He walked over to our table. He was in pretty good health, I mean, considering what was all going on. He had a left-sided fistulagram, and then Dr. Walters wasn't exactly sure where in the fistulagram he was going to access, but he would kind of use ultrasound to determine where he would want to access from. So prior to his arrival, our nurses called, made sure he was off all the medications he needed to be before the night before the procedure, or if it was aspirin or any kind of blood thinning medication, it was 5 days prior. He was NPO after midnight. He went to ambulatory care, which is our pre and post observation unit. The consent was done up in AMC with Dr. Walters and one of the nurses up there. We weren't really sure what we were going to find when we started the procedure, if we would have had to balloon or if there wasn't really anything there that we could take care of, or if it would have had him in surgery. So when the patient got down to us, we hooked him up to blood pressure, pulse ox, oxygen monitor. I don't believe we ended up giving him oxygen. He was doing really well. He fell asleep right after the medicine. He was supine, but we had his left arm in anatomically correct position on an arm board. We did use a strap just so he could kind of relax his arm and not have to focus on keeping it right there. We used 55 minutes of sedation and 50 milliliters of ICU 300 contrast. During the procedure, he was able to walk, like I said. So he walked over to the table, got on the table. We got him comfortable in a position that he was okay with. At the end of the exam, he was very heavily sedated, pretty sleepy still, so we ended up using a slider board to get him back over. So Dr. Walters always likes to run the fluoro pedal. We run the table a good majority of the time just because he's at the head focusing on the wires and the position of everything, but he does like to run the table every once in a while. So he's the one kind of in control of fluoro. And he's really good about knowing, okay, I'm going to do this run for this long, so I'm going to get off the pedal, which is really good. This patient was in no precautions. The crash cart was in the same room that we were in. It was right across from us, so if anything were to happen, it was right there. Oh, as I bump my camera here. So our sterile drapes come in our kit. Pretty basic sterile. We used an angio tray, so we had the angio cover, which I did cut holes into to fit around the arm. We used the stockinette, which I don't have listed. We used ultrasound, we had an II cover, and then we had the monitor cover. We used ChloraPrep to prep up the arm. Our needle, Dr. Walters likes to begin with a 30 gauge, just a little smaller needle to numb up, and then he'll go up to a 25, and then a long 25, and then we'll go in the micropuncture needle. He just likes to make sure his patients are pretty well numb before we begin the procedure, so he lets that work for a little bit. We started with a 5 French sheath. Oh my gosh, my dog's barking. We started with a 5 French sheath, and we were able to get a good majority of stuff through that, but once we upsized our balloon, we had to switch over to a 6 French sheath just to make sure everything went through. We stuck with a Benson the entire time, and we ended up not needing a catheter for moving. We did use 3 different types of balloons. We started with a 6 millimeter by 8 centimeter balloon. Then we went up to a 9 millimeter by 6 centimeter balloon, and then a 10 millimeter by 4 centimeter balloon. So for this case, we ended up accessing the cephalic vein in the fistulagram. We used ultrasound to find our vein. After that, that's where he used the numbing needle, and then we stuck with the micropuncture and put the sheath in. After that, we did multiple fluoro runs to find out where the stenosis was or if there was anything. After we did the first angio run, we saw that there was a central cephalic vein stenosis, which was 70 to 80% occluded. So after we found out where the stenosis was, we went in, we prepped our balloons and went in with the balloons. We ballooned once, took that out, re-shot with contrast, then we did another ballooning because it wasn't really opening the way he wanted it to. So same process, prep the balloon, put the balloon through, shot with contrast to see if it was opening any better, and then the same thing with the third balloon. After the third balloon, it was significantly better, which was good. We ended up, Dr. Walters didn't want to cause any harm to the patient, so we ended up being done with that. We saw a multitude of veins, the subclavian, the cephalic. There was a lot of different kind of veins, but the cephalic was the one that we were most concerned about. So this is kind of a reference of the stenosis, how it drops in. The stenosis was a lot smaller than this when we started, and it did get pretty big and a pretty good size after we had ballooned a couple times, which was amazing. So we held pressure on the fistulagram, which is not like holding arterial pressure. I've held both now, which is still intimidating, but it's one of those things that with time I will get better at. We held the pressure. After we were done, the patient stayed with us just for a little longer so we could get our final conscious sedation times. Then we slid them over to the bed, took them upstairs, kind of explained that we don't want him really using his arm. We want that clot to kind of stay for a while, or to form, so nothing will reopen. He was pretty sleepy even when he left us, so he went upstairs to kind of come out of this sedation. He was more awake. And then after that, we held him for, I believe it was 6 hours we held him for, just to make sure everything was good. And after that, we let him go home, and that is my fistulagram. Thanks, guys.